Welcome to Measuring Up, Meeting Program Standards for Hospital at Home, a webinar sponsored by the Hospital at Home Users Group, presented in partnership with the American Academy of Home Care Medicine and the American Hospital Association. We'd also like to recognize the generous support of the John A. Hartford Foundation for the Users Group and this webinar series. Please note that the slides and the webinar will be available afterwards on our Technical Assistance Center on the events page of hahusersgroup.org. It's now my pleasure to introduce our moderators for today's webinar. First, Dr. Bruce Leff, a member of the Hospital at Home Users Group leadership team. Dr. Leff is a professor of medicine at the Johns Hopkins University School of Medicine, where he directs the Center for Transformative Geriatric Research. He will be teamed with Dr. David Levine, also a leader of the Hospital at Home Users Group. Dr. Levine is assistant professor at Harvard Medical School and medical director of strategy and innovation for home hospital at Brigham and Women's Hospital. Drs. Leff and Levine, please take us away.
Thank you, John. It's great to be here on behalf of the Users Group. So for those of you not familiar with the Hospital at Home Users Group, our group, with the support of the John A. Hartford Foundation, has been providing technical assistance to the hospital at home community over the last few years. We invite you to check out our website, where we've posted a bevy of free technical assistance tools for hospital at home, including our webinar series, which you'll see on the next slide. So if you have an interest in binge watching Hospital at Home User Group webinars, feel free to go to the Technical Assistance Center on the website and binge to your heart's delight. I think you'll find a lot of these materials still quite relevant, quite useful for programs that are both mature and programs that are getting started in the hospital at home space. We'd love to alert you to the upcoming Hospital at Home Users Group annual meeting. This is a virtual meeting. It will be held on October 27th. Be sure to register. We have some wonderful keynotes from Dr. Bob Wachter and Dr. Narav Shah. We have some great debates that'll be moderated by Dr. Levine this year without costumes, I believe. Each program can invite up to 2 patients and caregivers to attend gratis. So we'd like to have that level of participation as well. And next. So the Hospital at Home Users Group is a special interest group of the American Academy of Home Care Medicine, which is hosting its annual in-person meeting in Orlando, October 28th and 29th. So we also encourage you to register and attend. There will be some sessions during that meeting devoted to hospital at home, but the American Academy of Home Care Medicine also looks and has great interest in the full spectrum of home-based medical care models and care. So have a look at the Academy meeting as well. So today's webinar, Measuring Up, Meeting Program Standards for Hospital at Home. Let me just very briefly introduce our panelists today. First, we have Tara Hoare, who's the medical director of the Vanderbilt Hospital to Home program. Peter Reed, the medical director of Hospital to Home Unity Point Health in the great state of Iowa. We have Michael Dalton, vice president, virtual care enterprise at Metro Health, where I think their baseball team is doing quite well. And finally, Rob Boxer, medical director of clinical operation at Brigham and Women's Hospital. Don't think the Red Sox are doing too well this year. So before we get started with the panel and what I think will be a very lively discussion, just wanted to give some very brief background on program standards development that the Hospital at Home Users Group Program Standards Work Group has been engaged with the help of the Hospital at Home User Group community. So, the first question you might ask yourself is like, why bother to develop program standards? The Users Group thought it was important that hospital at home provide high quality of care across the country with clear definition. If you don't have definition of your model, you really do not have a model of care. We also learned over time that there were many groups that were really interested in our point of view as the folks who are doing this model regarding what program standards should look like, and we thought that we should have a strong voice in that. We also wanted to provide stakeholders with a unified set of hospital at home user group developed embedded standards that organizations like CMS and the Joint Commission and NCQA and others that have a a strong and important interest in making sure our patients receive high quality, safe care could look to as they evolve their thinking on hospital at home. So this is what we in the program standards work group, with the help of the community, have been involved with since about 2020. We did a lot of basic work to develop program standard domains, and we'll talk about some of those later in our discussion. We did some work polling user group members regarding this draft list of program standard domains, and we put out a call to the community to contribute to the draft list, add, amend, or delete. There were multiple rounds of the work group to clarify the domains and standards. We crosswalked our draft standards to CMS requirements under the acute hospital care at home waiver. We then put out that draft to the hospital at home users group community for an open comment period. Those comments came back. The program standards worked with those comments and reiterated and redrafted the program standards. And with that, we have a final set of program standards, or program standards circa 2022. And what we're doing now is we're going to be publishing those in some form. And we are also embarking now on a survey of hospital at home user group members at the program level. So a member is a program that has taken care of at least one hospital at home patient, on how their programs compare to the standards. This will help with describing the current state of the field, benchmarking the field, and we think this will be of service to the field. And we plan to do this type of survey on an annual basis to see how the field develops. So these are the program standard domains. These are the high-level buckets under which there are multiple substandards. And these are, number 1, leadership; number 2, education and training; number 3, human resources management; number 4, information systems and management; number 5, quality and quality improvement; number 6, safe practice and environment; and number 7, clinical standards and protocols. So with that, I'm going to turn it over to David, who's going to moderate what I hope will be a very lively discussion among our wonderful panelists. And if you want to know how wonderful they are, feel free to ask them in the Q&A.
Thank you, Bruce. It's great to be with everybody. And again, big thanks to all 4 of our panelists for being with us. We are not going to bore you by going through dozens of slides on each program standard. That would be terrible. So instead, what we've decided to do is pick several program standards that we're going to discuss in detail. And we're going to use a plus minus delta approach, where we're going to ask one of the panelists to start off describing kind of how their program really tries to look at this standard. It may be that they have passed this standard with flying colors and do absolutely everything that is asked of them. Maybe that they actually struggle with this standard, or it may be that they've gone through quite a process of change already regarding this standard in order to try to achieve it. And so we want to almost emulate kind of the process that we're going to be asking every single hospital home user group member to do when they go through this survey and look at kind of, are we really meeting that standard, exceeding the standard, or is this an area where maybe we're struggling and we want to do better? And so full disclosure, we have 4 amazing programs represented here today. None of them are perfect. Sorry, guys, you're all great, but none of them are perfect. And that's actually the point. We want to emphasize that programs have gone through change. They might be struggling with certain standards. And a couple times, like they'll tell you, we've got this, no problem. We're passing this one with flying colors. But we really, we want people, and we appreciate everyone's vulnerability today, and recognize that every program is in evolution, no matter how many years you've been open to caring for patients. And so with that, on the next slide, we will dig in to the first one on the next slide. This is in the domain of training and education. And so this is the first standard that we're going to kind of get at. And it states that a program needs to provide clinical competency-based training for hospital-to-home clinicians, either employed or contracted, to deliver high-quality, safe, ethical care. And as you'll see, each standard has several bullet points. And a lot of these might be aspirational, right? It may be that, we'd like you to be able to hit all of these, but you may not be able to. And so we want professional standards of the discipline, and adapting them to clinical care for hospital at home. We want standard onboarding, shadowing experiences that occur, onboarding that's reflecting up-to-date evidence bases, observation of clinical competency by senior clinicians in home hospital, classroom and field-based teaching and assessments, interdisciplinary training, and then all field staff have BLS certification. And so that's the standard. We're actually going to start off with Peter. And Peter, would love to kind of get your take on how Unity Point would look at a standard like this, and kind of where you all feel you might be in terms of we've got all these, we're struggling with some, or maybe we've gone through some intense changes already regarding this standard.
Yeah, thank you, David. I can't agree with you guys more. We are always changing and evolving. And so as we look at all these standards, we're kind of in different spots. We struggle with a few of them, we're changing, and then we're on top of it for. So a little background about our program, just to kind of level set everyone. Care at Home Clinic, that's our clinic name, is a population health service line that was developed with ambulatory-based options of care to reduce our Unity Point accountable care patients need for that ED, hospital, or SNF utilization. One of our tools or services that we offer is hospital to home. We are a hub and spoke model with clinic services across Iowa in regional markets, and therefore onboarding and training is challenged by that geographic footprint. We do follow standard onboarding with our colleagues with a competency checklist and about 4 to 6 weeks of onboarding with a mix of classroom and hands-on, beginning with shadowing, coaching at the elbow, then coaching remotely. This is done with all new hires across the state of Iowa for us, and they come to our central Iowa market. The challenge is that geographical footprint is that they have to travel for that experience. So we really struggle with that ongoing field-based teaching and assessments due to the travel requirements, sometimes up to several hundred miles. And the shadowing experience, we think that's a stretch for us, as we would love for our providers to follow with hospitalist specialists in different clinics. And so we kind of get around that by recruiting from the hospitalists or internal medicine fields or people with significant backgrounds in home health. And so again, we're continually evolving. And so teaching and coaching is done remotely for us using Teams or Zoom or other web-based platforms. So it's difficult, but not impossible for us. So.
Yeah, thanks, Peter. Tara, I'm curious kind of how are you all looking at this at Vanderbilt, and kind of, I think you've mentioned in the past kind of changes with your nursing roles and things that I'd be curious to get your thoughts.
Yes. So similar to what's been said already, I think this is something that we have continuously learned from our experience and from the population here at Vanderbilt to adapt our teaching as we go. And so we, in particular with our nursing roles, our program has 3 distinct nursing roles. We have an intake nurse who's based out of the hospital and works on identifying patients who are appropriate for participation in the program. We have our command center nurse who does the remote patient monitoring. And then we have our field nurses who actually go to the patient's homes each day. But what we found is that particularly because of staffing and call outs, we really needed to have our nurses all be cross-trained to cover for one another. But in addition, the cross-training helps them to be able to do their own main role more effectively because they understand all the levels of care that a patient receives when they go through the program. In addition, I think we are continuously looking at our staff's competencies. And so we had standard competencies to be, caring for medicine patients. However, we're continuously looking at the needs of the institution and looking at what patients could benefit from their care being provided in the home setting and then looking back to say, what competencies do our staff need to have in order to effectively care for that population? So things that we've identified most recently have been caring for patients with wound vacs or patients on TPN. And those are things that we had to work to have our nurses and our providers be competent in caring for. And then as we investigate ways to care for patients who are post-surgery, we've looked at other things in terms of drain removal and wound care as well.
Yeah, a huge amount of cross-training. I'm curious, Tara, like in terms of making sure that all those team members have a unified training, are you saying like everybody has to have the full kit and caboodle, or is it still okay to kind of have just part of the training? Like, oh, maybe you haven't been wound vac trained. How are you all kind of approaching that?
I think as we add different competencies for our team, as we onboard new members of the team, it will be part of the standard onboarding for everyone.
Got it. And that's actually something I remember, Peter, you mentioning, like almost as you do onboarding more and more, you realize the things that you're missing and you realize the things that oh gosh, actually, we should be onboarding somebody for doing this. And we've just assumed that people had this competency before.
Exactly.
Yeah. All right, great. Any other thoughts from Michael or Rob on this standard and kind of how you all approach it?
I think one factor that we definitely consider is not just the kind of education standards, at the beginning when somebody is starting, but kind of what is the ongoing support that somebody is going to need on a day-to-day basis as they're gaining experience and practice, knowing that learning often takes multiple times, and there may be certain scenarios that they just haven't encountered during that preceptorship period. And so I think we've been incredibly thoughtful about what are the kind of structures we have in place in the daily workflow that help support kind of ongoing learning and support.
Nice, yeah, great. And I also just want to call out just two things. One from the Q&A, a question about kind of why is the standard calling out BLS as opposed to ALS training? I think it's a great question. I actually remember our work group talked about this for a really long time. Some folks felt this shouldn't even be a requirement. Other folks felt it should be ALS. I think we kind of got to a middle ground of at least BLS certification. And again, part of these standards is you all are always welcome to, soar above. And so if you all want all of your clinicians to be ACLS certified, great, you'd automatically kind of hit that standard. But I think a good question. And then the only other thing I just wanted to clarify is that really, when we're talking about these clinicians, we want to be as broad as possible. I am positive we have physical therapists, we have occupational therapists, social work, everybody is on this call right now. We have, well over 200 people on this call right now. We just want to be inclusive of those people as well. And so I think a lot of what's been said so far for nurses and physicians is very much also pertinent for other clinical specialists who participate in the care of acutely ill patients at home. So this is in the next category of quality and quality improvement. And this standard is really all about developing and implementing a quality improvement plan, right? There's several standards inside of this domain, but we chose just one of them here and want to make sure that your program has a documented QI process. It has data collection systems that are relevant to QI, designates personnel to coordinate QI processes, receives and acts on input from a safety committee when there's an issue identified, which is part of the CMS requirement if your program happens to be CMS waivered, and makes work transparent using a dashboard and review system, and then has linkages of the QI system into leadership in the larger system where applicable. Wanted to start off this time, Michael, with kind of Metro Health's experience and how you would kind of assess your program as measuring up to this standard.
Sure. So just by background, our hospital in the home program sits within our virtual care enterprise, which really is an overarching umbrella for non-traditional care that we deliver in the home or virtually. And so we're still relatively new. I think we're about a year and a half into our program and what we've been able to offer. And I think what we've done to date, especially in kind of where we're in that delta, where the opportunity is really being able to truly integrate our quality improvement efforts into the larger system-wide quality improvement processes and systems, which is, I can just tell you initially, we were, if we had an outage or there was a power outage or a network failure or something that would happen, the emergency management team actually sits right outside of me and they'd be like, huh, how does that impact hospital in the home? And it had to be this, and now it's part of that cadence, and it's part of an understanding of how are we impacting not just what's happening behind me within our towers, but actually what's happening in the home, what's happening in what we have with our command center. And we've been able to build that in. So today, our virtual care enterprise clinical team, as well as then we have a supporting team called the Digital Care Services, who handles all of our technology, equipment, the platform. They are engaged in two separate but aligned quality improvement processes or programs within our organization. We participate in our daily safety huddle, and then we have cascading huddles that come from our frontline staff all the way up to our executive team, and our hospital and the home census and any quality or safety issues are shared through this format. And just to be clear, this did not exist until probably like earlier this year, and that further embedding within our quality improvement system-wide didn't happen until I'd say really recently. We do have a documented QI process. We kind of use a standard PDSA cycle, and then in the case of a safety event, we utilize a swarm process where we quickly perform an incident report, perform a 5 why analysis, we examine the root causes, any contributing factors, and then we develop a set of recommendations and improvements that we should take. But this is all kind of embedded within the larger system safety and quality improvement framework. We did recently hire a new director who, among her other responsibilities, she's working with our clinical leaders to further implement our quality improvement and safety efforts. But I mean, I'll just say a lot of that fell onto our operational leadership to own that. And there was a lot. We're building out new programs that we need to be able to deliver both virtually and in the home. And I think just having that dedicated focus around quality improvement and safety is something that we needed. We knew that we needed to have that in place to shore up the program and really build on that moving forward.
Great, thanks, Michael. How are you guys, if at all, using dashboards right now to kind of make the work transparent?
So we have spent an inordinate amount of time building out dashboards within Epic, and just we did not go live with our acute hospital in the home program until we had built out a virtual inpatient unit within Epic and had all the dashboards tailored to what we would want for our virtual inpatient unit. But that was just something that we said was non-negotiable from a quality and safety perspective, but also just from being able to track from our respective dashboards. And that is transparent. It's shared across the system, and from finance to quality to clinical, everybody can kind of see our performance and how we're doing.
It's great. Thank you. It definitely seems like there's been a big evolution kind of with respect to this standard. Tara, curious kind of for your take at Vanderbilt, kind of plus minus delta.
Yeah, so I think when we first envisioned creating a hospital at home program here, initially the program was going to lie in some of our other home-based services, so sort of be built out of home care. And as we continue to grow this and really see it as an extension of our inpatient hospital, the leadership changed. And so it was pulled more into the hospital. And like Michael's team, we also did not go live with our program until we created a virtual unit in Epic. And this allowed us to really be an extension of all of the quality and safety systems that are put in place for our inpatient hospital, and allowed us to track it and leverage those systems. The other thing is that we have special reviews. So we have a red cap system where we review all of our patient escalations, as well as our 30-day readmissions. And so this is a way for us to track them, but also a way to have an interdisciplinary review so we can learn from one another and try to perfect our processes so that we can see room for improvement in the future. I think it's also really important to look at what are the metrics that we should be tracking for a hospital at home program. And so CMS has very basic metrics, but we wanted to look at similar things that would be quality metrics for the inpatient hospital. And so our system allows us to track many other things like falls with serious injuries, hospital acquired infections, 30-day readmissions. And so by being an extension of the hospital's analytics system, we're able to track all of those things and to review them in the standard manner that would be done for the inpatient hospital.
One thing that was important for us too was, I'll just say, I think we've seen an evolution, but is length of stay was really important because we tended to leave patients too long in the home because we wanted to make sure that they were okay. I think we needed to start evaluating that, and we started looking at like what that length of stay was. Like we just asked ourselves, is that actually absolutely necessary? It's the same questions we have over in the inpatient wards, but that was really important for us, is just to evaluate our program as well.
Yeah, it's a good point. I'm curious, like either Peter or Rob, is there one of these that kind of your programs struggle with right now in terms of kind of Q or QI?
I'll offer that we struggled with that creation of that dashboard and finding bandwidth within the organization to create that, since there are a lot of different priorities out there. And this is a newer program, advocating that we need the analytic support. That was a struggle for us. I will kind of go back to what Michael was talking about, the length of stay. We looked at that as well. We some of the metrics we additionally track are the 7, 30, and 60-day ED and hospital utilization. And along that length of stay, we then went back and said, gosh, some of our length of stay are extending. And so the QI process allowed us to do a PDSA cycle and allowed us to rethink about length of stay, and maybe we should take this patient into one of our other levels of services, effectively discharging them from the hospital, but moving them stepwise through our other care at home services, supporting that patient as they recover from their acute illness, but not using that high intensity of the acute hospital care at home or inpatient hospital to home requirements.
Great. All right. Thanks, guys. Let's move on to the next standard. This will be in our HR domain. And so this one here is really management of contracted services and vendors. Know that this is an area that can be actually quite painful for some hospital programs. And so here, to measure up, we want programs to have orientation programs for their partners that educate them. Partners need to complete the orientation program that you have for them, right? Nice to have it, but not nice if nobody does it. And a verification process that they're actually meeting the criteria that you have set for them. Wanna go start with Rob, you on this one, kind of tell us how Brigham measures up to this standard, plus minus delta.
Thanks, David. And I'll just answer, I think there's in the question and answer, just a comment on the number of patients we've seen in the past 12 months for each program. We've seen about 750 patients in the hospital home program at Brigham and Women's. And we do use contracted medics, MIH medics, for some of our staffing. And this has definitely been an area that has evolved and honestly been a struggle at times, particularly in the last couple of years, as a lot of the MIH industry and the medic industry was, going through their own constraints around staffing. And, I think trying to kind of hold an outside vendor accountable for meeting our program standards in terms of workflows, and particularly as they were working with a number of different partners, and were under staffing constraints was really challenging. I think some of the lessons learned, especially as contracts came up for renewal, was making sure that we had within the actual contract not just kind of service line agreements around the delivery of care, but service line agreements around the kind of onboarding expectations and what that process would look like. Kind of who was responsible for it, who was responsible for the equipment that was kind of needed for it, and who is responsible for kind of maintaining assessments. And I think that it just kind of raises the other area of just making that decision of whether, when you're working with a vendor, whether you're going to kind of share with them what your process is and kind of put the expectation that they're going to train their own staff working in your program up to your standard, or whether you are going to take it on yourself to kind of do that training. And I don't know that there is 100%, or that we've even honestly found the 100% right answer there. I think the things that have improved things for us is really identifying kind of key partners within the vendors, who are going to be just good partners to kind of have clear expectations around kind of who's responsible for what when you're thinking about training to workflows.
Thanks, Arvin. I'm curious, kind of what sort of verification process, if at all, maybe this is an area kind of struggle is happening for contracted vendors?
Yeah, for us, it is an area that I think that we can still improve. We've a lot of the vendors are now also kind of working under a kind of a preceptorship where they are working with a medic or a nurse, kind of familiar with our workflows, who is kind of going through a checklist and a kind of assessments. I think it could be an area that can be even more robust. I think it covers some of our basic workflows, but I think that just even having something for not just that initial onboarding period, but again, maintaining competency, because there could be lots of staff that may work less frequently kind of with your program than others. And just again, as they try to meet staffing challenges, I think, in order to kind of fulfill visits, sometimes you have staff members from your vendors who are less familiar with your program than others. And that's a real challenge.
Yeah, thank you. It is a fascinating concept of like auditing, how to audit appropriately in home hospitals, especially because we're such a decentralized care model. And some of the vendors that we're talking about here are the folks that help us in the off hours when we're like least staff. So how do you audit the folks that you can almost see the least? Tara, I'd be curious to get your thoughts for Vanderbilt, kind of how things you all have struggled with or changing or things of that sort.
Yep. So I think we, made, as every hospital at home program has to decide is, with each service, are you going to contract with another vendor or provide the services yourself? And there's a trade-off. And so many of the services that we sought from vendors at the beginning, we've made some adjustments to over time. I think for many of the reasons that have been highlighted, the verification process is really challenging. For some of them, it has been as simple as we have requirements for how fast the vendor has to get that service to the patient. And for things like oxygen and food, that is a very tight window. And there is a lot of promising that happens, but overall, sometimes the vendors don't truly understand that this is not the same as traditional home care, and that when we need something in an expedited fashion, it's because the patient is hospitalized and their needs escalate and they need that service. So we initially had, I think this is pretty common, we encountered this problem with our food vendor. We realized that this was something that many other programs had encountered as well, which is that the vendor was not able to provide meals within about 48 hours of when the order was placed. And so we had a way to have stable meals to provide in the meantime, but found that our staff that was in the home found that these meals were not really appropriate for the diets that were ordered for patients and really nutritious enough for the needs for a patient who was acutely ill. And so we were able to, over time, use this to bring back to Vanderbilt to find a way within our Vanderbilt system to have our cafeteria and our own in-hospital vendor provide meals for our patients. And it's something that we needed to use our own experience and prove that something was insufficient to be able to drive it forward on our own. Similar for oxygen use for our patients.
Got it. Yeah, really nice. And actually, that's just a segue. I wanted to ask Peter, I think you have a unique situation, Union Point, doing a lot of insourcing to the point where you don't really have vendors for many things. I'd be curious if you could kind of speak to that. And then also, we have a great question from Stephanie Murphy in the Q&A about kind of time frame for reevaluation of how well your partners are doing for you, right? So that's nice. You check it out once. Like, do you do it every year? Like, and particularly because so much of your work is in-source, Peter, be curious if you could answer, how often are you kind of, re-verifying that your partners are doing what they're supposed to be doing?
Yeah, great question, David. Yes, we are in a unique position that a majority of our services are in-sourced or aligned with Unity Point Health, our home medical equipment, our home care, our home infusion, all of that lives within Unity Point. So we have alignment of our values, and our strategic goals are aligned. And so that makes the pull a little bit easier. We do outsource a few things like radiology we have to partner with. And so it kind of goes back to that quality improvement arm, is being able to track how quickly can vendors get oxygen out to our patients. In-source, they're usually beating our patient home from the ER. They've already dropped it off at their house, which is fantastic. However, radiology and x-rays, we're having to poke and prod them. And so it goes back to that value alignment to say, hey, these patients are very sick. We want to be a great partner with you, and we need to have our values aligned. And so being able to have that quality and allows you to kind of hold people's feet to the fire, so to speak, to say, 36% of the time you are outside the window. That's not acceptable.
Yeah.
And so that's why having that strong analytics and quality is really, really important, because then you can back it up with data.
Yeah. So it sounds like you're almost doing it on a continuous process with
Yes.
your collaborators, which is probably kind of everybody's desired spot, but that's great.
Yeah.
All right. For time, I think we should move on to the second to last one, which is in our clinical standards category, and it's really on the role of a family and caregiver. Just kidding. That's next. We're going to do escalation next. That's the last one. So escalation. So for those who might be new to the term escalation, this is when a patient needs to return to the hospital and stay in the hospital at least overnight due to needing some sort of higher level of care, or because of patient and family preference. And so here, we're asking, in order to measure up, does the program have criteria to identify patients that require escalation? Do they have established procedures with transportation partners to accommodate escalation? Right, we don't want everybody just calling 911 for all escalations. That's inappropriate. Education of patients and caregivers regarding escalations. Right, how do we prepare families? How do we teach them on when and how to talk with their teams? And so for this one, wanted to turn first to you, Tara, to kind of get your, to Rob, to look at kind of how Brigham is looking at this.
Yeah, and I do think that this is an area that we've made a lot of improvements and are doing quite well in. I think we really kind of think about the escalations in kind of two different buckets. There's the kind of emergent and the kind of non-emergent, and the processes are a little bit different, and the considerations, just as you said, I think are non-emergent are probably more common and are a little bit more tricky. When it's an emergency, it's pretty straightforward, and we have a protocol, for how to transport the patient, who gets notified, kind of where they're going. For the non-emergent, it's a little bit different in how you kind of communicate this with patients and families that you're considering return, or they're considering return to the hospital, kind of what the role of the kind of clinical leadership team is. We found, especially as we've grown and have a lot of newer home hospital providers, there are times where, frankly, over the course of the year, that some patients get escalated, that a more experienced clinician said, hey, did you consider these options for being able to continue to care for them at home, and making sure, I think we kind of talked to our fellow attendings that reaching out and to the leadership and kind of bringing it up, sometimes even before discussing it with the patient, can be really helpful. Once that discussion of I think you may need to return to the hospital is kind of out there, that can really affect how a patient and family is feeling about being home. If you're then going to propose with more information, other options to keep them at home. I do think this is an important, both an area for shared decision making, and again, it neither should be that the home hospital team is just deciding for the patient that the right thing to do is to return to the hospital. Sometimes that's not the wishes of the patients and families, and there are other times where as a provider I may be comfortable for them being at home, but the patient or family might not be comfortable. And so I think both having a culture and a process to make sure that there's kind of shared decision making, and particularly with a lens to equity on this one, and to making sure that all of our patients feel empowered to express what their preferences are.
Yeah, really insightful, Rob. Thank you. And I think I really like your equity comment. And for those who haven't seen, Atrium has actually published 2 papers on different sorts of patient characteristics associated or not associated with escalation, which I think is really interesting and does look at that from an equity lens. Curious, Peter, for your thoughts here on kind of any sort of particular areas that inside of the family caregiver conversation and education around escalation.
Yeah, thanks, David. I think it also begins with I agree with Rob on the kind of 2 buckets, drop down emergency or kind of, gosh, we need to get you back. 2 buckets there. I also frame it with, picking the right patient, right selection for this service from the get-go will help you reduce the escalation, and being very proactive and upfront before you move them from the hospital or that facility setting back into their home, about the expectations for the trajectory of what's going on, and what would be the next steps if you needed to bring them back to that higher level of care. So it boils down to really educating the patient and caregiver. I can't stress that enough, because a lot of times a patient may be alone in the ER and their family's at home thinking they're being admitted to the hospital, and then suddenly they're back at home, and who allowed this to happen? So really having that buy-in from family goes a long way, at least in our experience. Thank you.
Great. Yeah, absolutely. And I think that education piece is important, that programs have it in place.
One thing I just wanted to add to it is that I think it's also important that we don't see escalation necessarily always as a failure. I think both, if we are truly taking care of acutely ill patients in home, we expect a certain, percentage, just like in the hospital, that a certain percentage is going to need the intensive care unit. We expect that a certain percentage, are going to need to go back to the hospital. And again, it goes down to kind of keeping track of what that is and making sure you're within your parameters.
Good point, Michael.
Yeah. I think I remember Dr. Sue talked about kind of, and this Shauna just posed this question of what's the target escalation rate. And I think we've gone anywhere between like 6 to 10 to 12%. Is that fair? Because basically, I just remember this like etched in my head. If it's less than 6, you're probably being a little bit conservative, and if it's more than 10 to 12, you're you're probably taking on additional risk. Is that what other programs, is that what you guys are looking at and trying to measure? Okay.
Yeah,
We're right in there.
I think that's right on, Michael. And we'll just toot the users group horn. That is part of our desire to collect data on a national level from everyone to look at those kinds of measures in our minimum data set request. But yeah, I think you're right on there, and it was a great question in the Q&A. All right, so for our last standard, we're going to go to clinical standards and protocols for role of the family and caregiver. And so here, in order to measure up, we'd expect programs to have policies detailing the role of the family and caregiver, any sort of education that's provided to those folks, training that's provided, if applicable, and then whether or not programs deploy team members like home health aides to the home to support the patient and the family and caregivers. Wanted this time to start off with Tara, kind of get your take on how this has maybe changed at Vanderbilt.
Yep. So when we started this program, we envisioned that, or started it with the requirement that any patient who was going to be considered for hospital at home needed to have a caregiver who was willing to be present in the home 24/7. What we learned is that this was very limiting for our patient population. And so, when you start with a bucket of patients who are hospitalized, you then look at payer requirements, you look at geographic restrictions, and then start looking at acuity and needs of the patients. This was just another thing that really limited the patients that we had the potential to approach for participation. In addition, we found that there were patients who would look like they were great candidates and seemed that they could care for themselves independently. And so it was not felt that this should be required for all patients across the board. And so we adopted a new process where the requirement for a caregiver is at the discretion of the admitting provider and nurse. So they do an assessment, and this is right now, it's not a very formal process. And so there is some variability amongst the providers. However, what they are looking for is an assessment of the functional and cognitive status of the patient to see if they are able to care for themselves independently, able to get around their home independently, and to do their end of the care that is required based on the clinical needs that the patient has during their hospitalization. And so we only make it a requirement depending on whether the patient functionally or cognitively needs assistance with those tasks. And so that has allowed us to provide services to a broader range of patients. We do not currently have home health aid services available, but that is something that we think would also help us to provide a better benefit to our patients. And so it's something that we're looking at adopting in the future.
Great. Thank you, Tara. Really interesting. Curious, Michael, for you to kind of talk about in sort of formal education challenges, scaling the training for families and caregivers.
Yeah, this is something that I'll just own. We do not have this well established. It's something that we need to better, I think, document and put together for our caregivers and our family members. To date, we've really focused more on, like, if we have to be able to provide care to our patients in the home when we're doing an assessment. I think I just saw that in the Q&A. We do make that assessment in the hospital or in the ED. But even in doing that, like, there's times where we probably have overestimated their ability to operate devices or be able to provide that input. And so sometimes we don't have a great fit. We do not have home health aides. That's something I would just go back to the contractor piece. We thought we had contractors, or in our contractor relationship, access to home health aides, and we don't. That had been then outsourced to another party. So this is an area where we really have, I think, an opportunity for improvement to be able to pull together what the role of the family and caregiver. We do have a formal virtual care patient family advisory committee that does incorporate our hospital in the home program and other programs that we deliver in the home, and get feedback and input as to what our approach and policies are for that. But we really need to have more formal policies in place for our team.
Nice, yeah, and thank you, Michael. Like adding a PFAC could be a nice future bullet point on this standard. I like that. Thank you. Rob, any kind of final thoughts from Brigham's perspective, kind of what we're doing for role of family caregiver?
No, I agree with a lot of what Tara and Michael had already said. It just that a lot of this starts at the consent process and before the patient's actually in the program, and to make sure that the patient and the caregivers really understand kind of what they should expect and what we may kind of expect from them. And think that is a key piece. And then really reinforcing that in your kind of admission workflows, both in kind of written materials as well as within the process of what the team is going through with the patient, because we know sometimes in the hospital all the patients and the caregivers are hearing is I'm going home, and not necessarily kind of understanding the full picture. We do use a lot of printed material to kind of, particularly for skill-based things that we might be asking a patient or a caregiver to do, and I think those are really helpful. But I think honestly our greatest strength is really the teaching that comes from our nurses, and are just an amazing kind of passionate group of clinicians who really whether it's teaching a patient or a family member to disconnect from the IV pump so that they get a more comfortable night of sleep, and really feeling confident and using best practices around education, including that just showing them, but kind of having them do teach backs. I think it really helps the patients and families feel comfortable with what's going on, and then having backups. And so sometimes when we realize that a patient or caregiver can't do something, having other processes to support them through, whether it's home health aides or MIH visits, to kind of do things so that that burden is not always on patients or families.
Great. Yeah, I think the concept of having a backup essentially is golden for home hospital. And I see some great questions also kind of about patients who live alone from Meg McGrath. And the answer is yes, the vast majority of home hospital programs do take care of patients that live alone, and have these backup systems for them, whether that's a deployable home health aide, things like that really do continue to serve patients who live by themselves. And definitely agree with the comment that kind of scaling up these kinds of supports for the family and caregivers may prevent escalation, but also definitely allows us to take more patients home who wouldn't be able to do so otherwise. All right, we're going to just move on and close up. Thank you to our panelists for kind of opening up your programs to these 5 standards. Really appreciate it. Just going to move on quickly to the next slide. Here we go. Yep. And so just want to give the community insight now into kind of where we're hoping to move this. We started out last year with a comment period, got really rich comments from everybody. As Bruce mentioned, a work group worked on this tirelessly for quite a bit of time, and then got our final program standards together. And now finally have sent out these surveys to program leads. And so if you are a member of the hospital home users group, meaning your program has taken care of just one acutely ill patient, that makes you a member. And we would love to have you complete your survey and essentially look at whether or not you feel like your program is measuring up to these standards. And you'll see that we actually do include some quantitative definitions of what measuring up means, right? Like how many bullet points in that measure do you have to achieve in order to measure up for right now, in terms of exceeding versus meeting the standard versus not meeting the standard. And so we're really excited to get those survey results, be able to present those back to the community to say, like, this is the state of the art in the United States. Predominantly, this is where we're doing well. This is actually where a lot of programs maybe are changing or struggling. And if you haven't heard about getting one of these surveys and you are a program lead, please contact Gabby. She will make sure that you are getting the survey in your inbox and that you can take it on RedCap. And next slide, Gabby. We are hoping to keep on going to our users group annual meeting, but we're hoping to essentially get all those wrapped up in the next month, leading up to our users group annual meeting. We, as Bruce said, are extremely excited to be coming together virtually again. We had, hundreds and hundreds of people come together last year for this, have a really, really fun lineup with a lot of talented folks. And so please be sure to register, and please be sure, we really want a lot of patients and family caregivers to attend. Every single program can bring 2 patients and family caregivers for free to the conference, completely remote. And we really want to hear their perspective while we're all working together. Just again, want to remind you, this webinar, including its slides, including all the past webinars, are completely free, posted on our website listed here. Please feel free to read them and watch them, and don't fall asleep at night doing so. And then, just again, as a reminder, our website here, our Technical Assistance Center, and again, a featured resource looking at an annotated CMS waiver for those groups that are still continuing to apply for new waivers. On the next slide, again, want to give a huge shout out and thank you to the John A. Hartford Foundation for their support of the Hospital at Home Users Group. Also to the American Hospital Association, who co-sponsors these webinars, as well as the American Academy of Home Care Medicine, who co-sponsors these webinars, and of which we are a special interest group. And that does it, folks. Thank you all so much for joining. A huge shout out to Tara, Rob, Peter, and Michael for their time. I know that they will be very open to take questions individually from folks, so please don't hesitate to reach out to them. And again, huge thanks for being with us. And we really look forward to seeing how everyone measures up and how the country measures up in the future, and getting this information back to you all. So please take that survey, and we'll be talking soon about the results, and hope to see you all virtually in just under a month or so for our annual meeting. Take care, and thanks all very much.